Bismillah ar-Rahman ar-Rahim. Dear undergraduate student, today we will give you a lectures about soft tissue neoplasm. First, I'll give you some general instructions. These lectures containing most of information you need for passing the exam. It containing most of the MCQ questions, informations, as well as short essay if it come. Lecture will be in English. I apologize for you, but I think medicine is learned and taught in English in Egypt, and you have to understand everything in English, and I think it's very easy. I will speak in fast way. It doesn't matter because you have the material and you can repeat the lectures as much as you need. Some more available information and more videos you can see in my YouTube channels. When you are searching, sorry, please stress on the H, which is in the last letter on my name. Lastly, I welcoming any feedback from all of you on my emails, personal email or personal WhatsApp. All of you, all of us pass through these steps. Please, if you are in any step of that, don't stop, go forward, go up. Soft tissue neoplasm. The ideas of this lecture will be no different type of soft tissue neoplasm, recognize clinical presentation of it, determine investigation needed to diagnose, and lastly, know different methods of soft tissue treatment. Collectively, types of soft tissue neoplasm, clinical presentation, investigation needed, and treatment of it. First, what's neoplasm and what's soft tissue neoplasm? Neoplasm in general is specific tissue growth without known stimuli, not responding to or either stimuli or controlling methods of your body. It's uncontrollable, unusefulness, may disseminate locally or systemically, and this unfortunately may cause your death. What's about soft tissue neoplasm? It is any mesenchymal origin neoplasm. During fetal life, you have endoderm, mesoderm, ectoderm. Endoderm and ectoderm will develop from it all the carcinoma. But mesoderm in between developed soft tissue neoplasm or soft tissue sarcomas. This except some is derived from the mesenchyme, but we don't include it in soft tissue neoplasm, comes from brain or its coverage, or come from blood or lymphatics like lymphoma, leukemia. These are special tumors and with special behavior and classification. Classification of soft tissue tumors is either benign tumors, and it's the most common one, thanks God, or malignant, fortunately rare, and in between it the locally malignant. As we said in the general introduction lectures about surgical oncology, we define locally malignant and its feature. What is the most common soft tissue neoplasm? Lipoma. What is the most common soft tissue tumors? Lipoma. What is the most common soft tissue benign lesion? Lipoma. Three types of different way of MCQ questions with the same information. Lipoma. It's the most common. All of the body could be affected by lipoma except the areas where you don't have fat cells. You don't have fat cells in your eyelids, and you don't have fat cells in the glands beans. So in this area you cannot have a lipoma. Favorite site of lipoma is the head and neck, shoulder, abdominal wall, and thigh. Sometimes, as in the pictures you see here, the lipoma comes as a multiple all over the body, and it is a hereditary autosomal disease, which we called it Derkam disease. Classification of lipoma, we have a different classification of lipoma. We have pathological classification, anatomical classification. So about anatomical classification, the most common one of it is subcutaneous lipoma. Another MCQ question. Most common site of lipoma is subcutaneous. Second one, intermuscular. Third one, retroperitoneal. This is will present about more than 95% of all lipomas. Then subfacial, subserosal, submucosal, subsynovial, intraarticular, paraosteal, CNS, not the brain coverage. This is all about 5 or 10%. This is an example of submucous lipoma on the inner part of your lip. It's yellowish, well defined. Another lipoma in the lower lip. A lipoma detected during endoscopy of the colon, submucous lipoma. Characters of benign lesions, well defined, smooth surface. Also, you can find lipoma in the vertebral column or even inside the brain from the fat cell connective tissue of the brain, not the brain itself. What about pathological type of lymphoma? Pathological types of lymphoma is either pure lipoma, which is also a common, but it's not the commonest like the anatomical side. Fibrolipoma, hemangiolipoma, neurolipomatosis, and lastly angiolipoma. Angiolipoma is the painful one. MCQ question. Angiolipoma is the painful type of lipoma. What about neurofibromatosis? Neurofibromatosis is a fatty cells with nerve cells. We have here, usually this is a nodule along a line of, anatomical line of a nerve. It is usually painless, slowly growing, but sometimes painful, especially if you press on it, it will become tender because of stimulation of the nerve nearby it. Sometimes von Recklinghausen disease is a systemic affection by a multiple grossly neurofibromatosis. This is multiple skin neurofibromatosis with cafe au lait pigmentation of the skin, and sometimes the gross disfigurement of this man, calling him an elephant man. This is an extensive form of neurofibromatosis, which we call it von Recklinghausen disease. Generally, the lipoma is presented as, by history, slowly growing painless lump. Don't forget to write down the history when he asked you about the clinical presentation. Clinical presentation including history and examination. All of you jump to the examination in your answer. In the examination, you will find not tender, well-defined, smooth surface lesion, soft, freely mobile with slippery edge. Soft, freely mobile. So when you try to detect its edge, it slipped underneath your finger. No enlarged lymph node in the lipoma because it's blind, and it shows pseudofluctuation. Details about fluctuation test and pseudofluctuation is presented in my lecture about examination of a lump. You can find it. But particularly, you have to know that lipoma is characterized by pseudofluctuation. That's say there is a moving of the wave in one direction, but not in all directions. Pathology of a lipoma, it's gross pathology and cut section. Gross pathology, well defined, well capsulated, low vascularity, yellowish in color. Cut section, homogeneous, pale. Under the microscope, with low power cluster of fat cells, with the high power, you will find a signet ring appearance of a cytoplasm filled with a fat lobule. Investigation needed for diagnosis of lipoma. Usually, lipomas diagnosed clinically. But if you need some investigation, you can do fine needle aspiration, you will find benign fat cells. Ultrasound, you will find a well circumscribed solid capsulated lesion, and sometimes you have to do a plain X-ray like in the left one to see intraosseous lipoma, and sometimes we do MRI to define its nature. Differential diagnosis of lipoma, it's a lesion, common swelling, but you have to differentiate between it and sebaceous cyst, where the sebaceous cyst has a punctum, and also the sebaceous cyst is fixed to the skin overlying. You cannot pinch up the skin overlying. Fibroma, in this photo particularly, it never has to be lipoma because the eyelid has no fat cells. This is a fibroma. Organized hematoma with a history of a mild or trivial trauma. Dermoid cyst, ganglion, which is a hyaline degeneration cystic lesion around the long tendon around the wrist. Branchial cysts, which is characterized by a swelling along the anterior border of sternocleidomastoid in younger age. All this has to be differentiated between it and subcutaneous lipoma or lipoma as general. There is a complications for lipoma. Although it's uncommon, but sometimes it inflammation, sometimes myxoid degeneration become more soft, calcification becomes more hard, pressure to nearby structure will cause pain or obstruction. Circumference change is not common, but the most common lipoma to have a circumference change is retroperitoneal lipoma. Another MCQ question. The most common lipoma to change to circumference change is retroperitoneal lipoma. Lastly, unsightness by itself is one of the complications. Sometimes the shape and the ugly shape of the lipoma by its huge size is a complication. Treatment of lipoma generally is excision, just excision, not wide excision, because it is well capsulated. Liposuction could be helpful, especially in diffuse form of lipoma. In cases of multiple tumors, there comes these, as we said before, excise the complaint one, the one which is disturbs the patient function or effort, or the complicated one, or the one you are suspected that it is has a malignant transformation. Now we have finished the benign soft tissue tumor, and we had a lipoma as an example of it. What about locally malignant tumors? We have two examples of soft tissue locally malignant tumor. First one is the desmoid, and second one is the dermatofibrosarcoma protuberans. What about desmoid? It is affecting usually the anterior abdominal wall in multi-bara women. It's slowly growing, hard mass. Some of it has an intra-abdominal extension. As we see here in the CT, the most of the tumor is intra-abdominal extension, and sometimes this kind is combined with the familial polyposis coli, and this is called Gardner syndrome. The combination of the desmoid anterior abdominal wall with familial polyposis coli is called Gardner syndrome. Pathology of the desmoid, it is not completely capsulated. It's partially capsulated, infiltrate nearby muscles as seen in this specimen. Under the microscope, it contains fibrous tissue, multinucleated plasmoid cells. Metastasize does not occur. It is locally malignant. Circumference change rarely occur, but it has a very high rate of local recurrence if not completely removed. Treatment: complete remove by wide excision with safety margin all around of a normal tissue all around. Muscular defect could be happen due to the wide excision and should be repaired with a mesh or local flap. Radiotherapy could be used as an adjuvant in recurrent case. If 2 or 3 recurrence come, give a radiotherapy as a prophylactic of further recurrence. What about dermatofibrosarcoma protuberans? Second, soft tissue local malignant tumors. It's rare, but it is pathognomonic. It looks like as it is. It usually affects young age, mixture of fibroblast and phagocytes, and as you see in these pictures, it is pathognomonic. It looks like you poured some cheesy material on your skin. It's slowly growing bluish dermal nodule. The usual affected area is trunk and shoulder and the back of the shoulder, as in this picture. Sometimes suddenly it may grow fast, ulcerate, and infiltrate surrounding structure. This not circumstance transformation, because it's still really metastasized. Treatment need wide local excision to make sure that you get rid of all of the tumor. General sentences said that all benign soft tissue neoplasm could be transformed into malignancy with different rate. What is the signs of transformation to malignant? Either rapid growth, bleeding, new vasculature, hard consistency, fixed surrounding tissue, infiltrating nearby structures and affecting it, or disseminating to lymph node or sending metastasis. If you suspect that there is malignant transformation of any benign tumors you have for a long time, please have a biopsy. Let's speak now about soft tissue sarcoma as an entity, sarcomas. It's usually, thanks God, it's rare, very rare. Soft tissue sarcoma is 1% of all human cancers. Usually it arises from mesenchymal tissue, as we said before. The size has no rule to tell you that this swelling is malignant or benign. Usually the benign lesions is presented with very large, slowly growing tumor, but the malignant sometimes large, sometimes small, as in this picture. The sarcoma differ from all the behavior of cancer, which is common, is the carcinoma. Carcinoma is the most common one, more than sarcoma. What the sarcoma differs from carcinoma? It affecting younger age group, its rapid rate of growth, rapid local invasion, sending more blood-borne metastases in the liver and lung, worse prognosis and less sensitive to radio and chemotherapy. So thanks God it is rare, it's only 1% of the human cancer. Common site of soft tissue sarcoma, as in this figure, the most common is the extremity, the upper limb and the lower limb. Okay, lower limb is the most common, retroperitoneal is the second one, and then upper limb and the rest. Okay, a common question, MCQ question about the most common site of affecting soft tissue sarcoma, lower limb. Pathology, usually the gross pathology of it is a mass, large, not capsulated, irregular edges, infiltrating nearby structure. The cut section show heterogeneous color with area of necrosis, area of blackish, hemorrhage, and some area of overgrowth with bulging surface. Pathological type. Under microscope, we can differentiate between liposarcoma, fibrohistosarcoma, fibrosarcoma, rhabdomyosarcoma, which affecting the skeletal muscles, leiomyosarcoma affecting the smooth muscle, Kaposi sarcoma, and lastly synovial sarcoma. This is under microscope differentiation. Types of sarcoma again in figures with liposarcoma. We added here also osteosarcoma, Ewing's sarcoma, and also we added GIST, which is locally malignant tumors affecting usually the GIT. Clinical pictures of soft tissue sarcoma. It usually resulted in a rapidly growing, painless swelling. This is history. Hot surface, dilated subcutaneous veins, ill-defined borders, as we see in these pictures. Variable inconsistency. Some area is soft due to degeneration and necrosis. Some area are hard. You have clinically to search for hepatomegaly as a common site of metastasis and lung by examination of the lung and chest. Common site of metastasis of soft sarcoma is lung. It is now evidence that histological grading and the clinical staging, histological grading, differentiation under microscope, and the clinical staging in spreading of the tumor in the body are more important as a prognostic indicator and in determining the treatment approach than the type itself. Soft tissue sarcoma staging. The standard of staging is TNM. The most simplest TNM staging is a soft tissue sarcoma because it is the rare tumor. So it has not a lot of modification. We'll see it's either T1 or T2, less than 5 centimeter or 5 centimeter and more in size, the T. N, either no regional lymph node involvement or regional lymph node affection. M0, M1, according to there is no dysynthesis or there is synthesis. That it is the TNM staging of soft tissue sarcoma, the simplest TNM staging. What about grading under microscope, which is the second most important prognostic factor? It's either well differentiated, modularly differentiated, poorly differentiated, or undifferentiated, as seen in the sequence of these three under microscope photos. Prognostic factors. These all factors has the worst prognosis. If the type is histocytoma, malignant histocytoma is having the worst prognostic type. These are common MCQ questions. Grading if it's undifferentiated. Staging if there is distant metastasis. Site if it's retroperitoneal. Recurrence is further recurrence having a more worse prognosis than first recurrence. And also if there is a biological marker like example P53. All this has a worst prognosis in soft tissue sarcomas. What investigation needed for soft tissue sarcoma? We divide investigation needed into three categories. Either investigation needed to detect the local extension of the tumor, the morphology of the tumor, the extension of the nearby structure. Secondly, we have to take a biopsy to prove malignancy of this lesion. And the third group of investigation is a metastatic workup to search for any metastasis in the body. Local extension of the tumors, the most common investigation done in the neck, abdomen, and thoracic lesion is the CT. Like you see in these photos of a huge retroperitoneal abdominal lesion, and here a mediastinal lesion in the chest, and both best investigate and best detected and determined by a CT. On the other hand, if the lesion is within the brain, vertebrae, musculature, or bone, or periphery, lower extremity, upper extremity, MRI is the best method of investigation to detect the extension of the tumor, as seen in these photos. What about ultrasound? It is important to know if the lesion is cystic or has a cystic necrotic areas or not, but the most important useful way of the ultrasound is to guide the core tissue biopsy, which will take biopsy from the lesion. So ultrasound is very important in guiding the needle to have a good bite of tissue, viable bite tissue. CT angiogram is very, very important in soft tissue sarcoma, especially in large size one and very difficult to be excised. Sometimes we define the feeding vessels and doing thromboembolization of these specific feeding vessels, aiming to shrinking the unresectable tumor or decreasing the size of the tumor and facilitates its resection. Other investigation which we need for local infiltration of the tumor, plain X-ray. Sometimes you find a soft tissue lesion in the thigh, as in this plain X-ray. Also, this plain X-ray can detect any bone destruction or a bony lesion, origin of this swelling. Sometimes also an arteriogram on some area is helpful to detect the vasculature and feeding vessels. Second group of investigation we need is taking a biopsy from this swelling to prove that it's malignant nature. A biopsy is these are the types of biopsy which you need, but the core tissue biopsy is the standard of care of all hard swelling as soft tissue sarcoma. This is an example of final aspiration. If any one of you does not see it before, it's an ordinary syringe, applied a vacuum on it, some few cells will pick it up, put it on a slide and examine it. It's an apparatus to help using one hand only, while the other hand can be identify the site of the tumor which you need. It's a very nice diagram to show you how the core needle biopsy is working. It's the step by step. The first step in the first row, both the inner needle and the outer needle together is introduced through a locally infiltrated anesthesia area of the skin nearby the tumors. Then we introduce the inner one with a gutter inside it first. Followed in the third line, we introduce the outer one, which is sharp and like knife. It cuts a part of the tissue and keep it in a gutter, in the gutter of the inner one. By withdraw both needle together and open it outside the patient, outside the human being, we can pick up a tissue line like as a half length of a matchstick. It is adequate tumors biopsy if you follow the instruction as it is and go through it. But this is the false way to use it. All the biopsy could be more accurate by using ultrasound or CT guidance. Sometimes the core biopsy is not useful. Sometimes the tumor is superficial, and at that area we can do incisional biopsy, like in these pictures we take a part of the tumor and a part of healthy tissue in one ellipse and then by 2 stitches close it, or by taking excisional biopsy when the tumor is very small. Suppose that you are managing with a lesion half a centimeter or 1 centimeter, you can excise it as a whole as an excisional biopsy. Third group of investigation is concentrating on find if there is metastasis or not. Soft tissue sarcoma is sending metastasis mainly to lung. Mainly to lung. Other sites like bone, liver, brain, and the rest of the areas containing the rest of it, but most common lung. Metastatic workup including plain X-ray of area with suspected bony pain. Like in this area you see a multiple osteolytic lesion in both hip bone and sacrum. Bone scanning by technician. This will be taken by metastatic area in the vertebrae and in the iliac bones. Also we can use CT specially to detect any metastasis in the chest and abdomen. Here is a normal CT chest of the abdomen, and this is a multiple metastatic lesion in the liver and a multiple metastatic lesion in the lung, in CT chest. What about PET scan? It's very useful in soft tissue sarcoma. It is measuring the metabolic function of sarcoma and surrounding tissue. This is a picture of very poor patient with a multiple affection with sarcomatous lesions all over his body. Surgical treatment of soft tissue sarcoma including in-block, wide local excision in all directions. As we will see in this diagram, if the tumor is like this, I have to take a margin of safety margin all around. In soft tissue sarcoma, at least I have to take 1 inch all around. Sometimes in soft tissue sarcoma in the lower limbs and in the limbs, we have to do what we call compartmental excision. If the tumor is involved in one of the compartmental groups of muscles, we will remove all the group of muscle in block to make sure that we remove this sarcoma and surround tissue in one block without missing any part. Some examples of this unblock removal of a part of a soft tissue sarcoma which cause tissue loss. And in this area we have to do tissue reconstruction. This tissue reconstruction, as I do before the operation, will taking from local flap. The tumor was there, I remove it, I immobilize this area and cover it by the defect, and here there's a loose skin which I can close it directly. Another example of a soft tissue sarcoma with drawing and a flap covering the shoulder after in-block removing of it. Another third example of a soft tissue sarcoma with deltopectoral flap rotating to cover it, and the giving area will be covered by split skin grafts. So wide excision in block of soft sarcoma is a standard of care. What about the other surgical treatment? Sometimes amputation for very huge, aggressive, or recurrent cases on a limb is the treatment. And sometimes excisions of localized solitary metastasis could be cured for some patient, but after complete excision of the primary and complete the adjuvant therapy, if he developed one solitary metastasis, we can do that. The only hope of cure of soft tissue sarcoma is early detection and aggressive treatment. If you notice any change, please see your doctors immediately. I will give you an example of one case of a lady 62 years old with painless rapid growing swelling outside the left thigh since 1 year, skin breaking down, awful discharge since 6 months. This is a picture of it by inspection. You can find a huge ugly shaped lesion in outer part of the lower area of the left thigh. The lesion is ulcerating with everted edge in some areas. The skin surrounding it is showing dilated veins. The floor of the ulcers is heterogeneous with some area of blackish necrosis, some area of soft degeneration, and some area of healthy granulation tissue, but it looks bad, malignant. Palpation, the base is hard, indurated, and it's attached to the underlying muscles by putting the muscle on action, and no enlarged lymph node. The standard care for detecting the extension of this lesion is MRI, because it lies in the lower extremities. MRI shows the lesions and shows that it is extended and infiltrating nearby muscle area, but small area. It's mainly coming out from soft tissue of subcutaneous. This is the excised specimen. I did it complete wide excision, and if we reverse this specimen, we find that I did detach it or remove a part of the muscle infiltrated by tumor to make sure that in block removal of soft tumor. This is the tissue loss which we are confronted with. We decided to reverse transverse rectus abdominis muscle, not taking the lower part of the tummy on the rectus muscle to reconstruct the breast, which is the usual way. No, we reverse it, take the upper part of the skin and soft tissue of the abdomen, depending about rectus muscle, and reverse it downward, passing it through a tunnel to cover the defect there. This is the defect which we ended with in the anti-abdominal wall. We put on it a Prolene mesh and cover it directly. During the operation, fixation of the flap and the abdomen is still open. We close the flap out and completing its fixation, and then go to the abdomen to do a mesh. This is 1 week after operation and about a month after operation with good healthy taking flap. This example to give you that this is not just in books, we are doing it practically. Taking home message: benign, locally malignant, and malignant. These are the types of soft tissue tumors you know. Commonest is the lipoma, or liposarcoma is the commonest in the malignant soft tissue. Suspicious of malignancy, you have to take biopsy at any time. CT and MRI are the main investigation. CT is better in the chest, neck, and abdomen. MRI is in the extremities. Wide excision is the golden standard of treatment. If you can do it as a primary treatment. Reconstruction is usually needed. Chemotherapy and radiotherapy has a very limited role in managing of soft tissue sarcoma. Thank you very much, and I hope and I wish all of you a lot of success by a lot of hard working. Thank you.